Awesome. Okay, so welcome everybody. This is it's nice to kind of virtually see all these names on the screen, maybe not the faces directly. Special welcome to Dr. Rajesh Fogla from Hyderabad, India. Thank you so much for joining us at this time. I know you're busy with a lot of lecturing and stuff, but it's great to have you here. If I could ask all the attendees to mute their mics so that we don't get feedback, that'd be great. Let me just mute this one person. And for those who, I know many people know who Dr. Fogla is. For those who are not, we are in for a treat. Dr. Fogla is from Hyderabad in India. He works at the Apollo hospital system, where he is the cornea clinic director and senior consultant. I think more importantly for me, on a personal level, he's been a great educator over many years now. So he's always been instrumental in forming the way I do surgeries and the way I think about corneal pathology. And so I think it's going to be a lot of fun for us to hear about his thoughts on what the latest trends are in corneal transplant surgery. So without further delay, Rajesh, it's all yours. Go ahead, please. Thank you so much again for accepting our invitation to present.
Thank you, Kashif. Thank you for giving me the opportunity to be part of your long series of CME programs that you have organized at Precision Cornea Center. So the topic that Kashif has given me to speak on is latest trends in corneal transplantations. I have no financial interests in the presentation. When we talk about talk about corneal transplantation, penetrating keratoplasty is still the most common corneal transplant procedure being performed worldwide. We have come more than a century since it was first described. But what is new now? If you look at this data from the Eye Bank Association of America, and if you look at the utilization of donor tissues, you will see that penetrating keratoplasty, there is a slightly decreasing trend from 2014 to 2019. At the same time, endothelial keratoplasty is on the rise. And later on, we'll see particularly this changes from primarily from DMEK nowadays. Anterior lamellar keratoplasty, in our part of the world, we do quite a number, but somehow in the United States, the number has been quite stagnant and we have not seen that increasing. I don't know about Canada, how the numbers go. So what is new in corneal transplantation? From full thickness corneal transplantation surgery, in the past 2 decades, we have moved on to doing selective layer transplantation or lamellar keratoplasty. So the lamellar keratoplasty is not new. It was prevalent even before, but somehow the visual outcomes were not as good as full thickness corneal graft. So it never became popular. So we witnessed a resurgence both in the anterior lamellar keratoplasty and the endothelial keratoplasty. And for different conditions affecting the cornea, you can selectively replace a layer without having to do a full thickness replacement. Coming to anterior lamellar keratoplasty, the surgical techniques can be divided into superficial anterior lamellar keratoplasty, when you replace corneal tissue somewhere in the anterior 200 microns. This can be done either using a microkeratome or the femtosecond laser. The second is the mid-stromal anterior lamellar keratoplasty or anterior lamellar keratoplasty, which is done between 200 to 400 microns. This usually requires sutures to be placed. It can be done manually using dissectors, microkeratome, or the femtosecond laser. And the last one, the deep anterior lamellar keratoplasty, where you replace almost about 85 to 90% of the corneal stroma with a donor tissue. And again, it's basically called as the pre-decimetic DALK, where you leave behind a little bit of stromal tissue, and decimetic DALK, where you try to expose what was thought to be the descemet's membrane. This can again be done by injecting stromal injection of air, fluid, or viscoelastic, or it can be done like a manual layer-by-layer technique. Advantages of anterior lamellar keratoplasty: primarily, the biggest advantage is that you retain the healthy host endothelium, thereby avoiding endothelial rejection. and the survival of the graft is much longer. Because of the reduced risk of rejection, you give a shorter duration of steroid therapy, thereby reducing the chances of induced cataract or secondary glaucoma. You perform the surgery in a closed chamber, so you avoid the risks of expulsive hemorrhage or endophthalmitis. You can do much larger diameter grafts without having to worry about increasing the risk of rejection. And even obtaining a tissue from the eye bank is easier because you don't want tissues with very good cell counts. Indications would be any condition wherein the host endothelium is healthy. In our practice, we do it mainly for ectatic disorders, various corneal scars, followed by dystrophic degeneration. Sometimes we'd use it for ocular surface reconstruction, and rarely for managing infections which do not come under control with medical therapy. Now let's look at some of the clinical examples. So this is a 16-year-old female with history of Reese-Buckler corneal dystrophy. She already had 2 prior excimer PTK procedures to remove these balls. Current visual acuity best corrected vision was 624, and she was hyperopic +6 with a pachymetry thickness of about 415 microns. And the lesions extended up to a depth of 111 microns on anterior segment OCT. So what we did for this patient was, we did something that we published in 2014. It's called the microkeratome-assisted 2-stage technique of superficial anterior lamellar keratoplasty. So in the first stage, we just create a LASIK flap. So here a 140 micron LASIK flap was created. You create the flap and replace it back in position. And then you go back 3 months later and you do a small central trephination. Here we use a 7mm trephine, and you remove that flap in that 7mm trephination. And then you prepare a similar flap from a donor tissue and replace it in the central area. Let's look at the video that we have here. So this is the flap being created using a microkeratome. That's the Amadeus with the 140 head. We created a nasal hinge. So this was done the same under topical anesthesia in both the eyes. So that's just the flap. If you see, if we lift up the flap, the underlying cornea is clear. So we dried it, we did it in the fellow eye. That's how it looked. Post-operatively, you can see the edge of the flap, and that's on anterior segment OCT. Also, you can see that the flap is fairly at a thickness of about 140 to 150 microns. And then we came back, we used the artificial chamber to create a 140 micron flap using a donor cornea. And then we went back to the patient's eye, marked the outline of the LASIK flap, used a 7mm trephine to do a partial thickness trephination, and then the central cornea was just peeled off. Now this has nice vertical edges. So, and the donor tissue that we prepared, we punched out a 7mm donor button from this cornea as well. And this was then placed into position, irrigating the interface, drying the edges, and then placing a bandage contact lens. Sorry, I think. So we look at so that's how it looked post-operatively. The advantage is that if it recurs, you can always go back and replace that central 7mm cap that you have created and place a fresh donor tissue as well. If you want for refractive correction, you can do a surface ablation as well. Similarly, this is another patient who had a central corneal contact lens wearer with a central corneal ulcer, which healed, leaving behind a central residual scar. He complained of glare while driving at night with ghosting of letters, and he was unwilling for rigid contact lens wear. His visual acuity best corrected was about 612 plus anterior segment OCT. The lesions extended to about 214 microns. So what we did was, in this case, instead of doing a 2-stage, we used a femtosecond laser to prepare, to perform an anterior lamellar dissection. The edges were angulated 150 degrees, so the posterior diameter was slightly larger than the anterior diameter. Similarly, we prepared the donor tissue as well. We peeled off the tissue. You can see there is slight adhesions in this area of the scar. We replaced the donor tissue without any sutures, and then we placed the bandage contact lens on top. That's how he looked post-operatively. You can see now the central visual axis is clear. His complaints of glare had disappeared. He was happy. And we also gave him the option of doing a topography-guided surface ablation to further refine his uncorrected vision 6 to 8 months later, once his refraction and topography was stable. This is another patient, again with Rees-Butler, but here the extension of the lesion was slightly deeper. There was a combination of granular dystrophy as well. So here we used the femtosecond laser, but since the depth of cut was about 280 microns, we placed a running suture with 4 cardinal sutures as well. Now these sutures can be removed in about a month, in 4 to 6 weeks time, because if you leave them longer, they will tend to become loose and they will induce vascularization, which can track into the interface and produce undesirable effects. So that's something about the anterior lamellar keratoplasty, which we do, but very infrequently. The most common technique that we do are the DALK surgery and the air injection or the big bubble technique described by Anwar and Tishman. That's the most common technique. So in this technique, you are using a 27 or a 30 gauge needle, which you introduce into the deep stroma. And when you inject air, you get this bubble that starts at the center. It has a dense white frothy margin, and it expands to the peripheral cornea. Usually it reaches up to a diameter of about 8.5 millimeter. This was the trephination was done using a femtosecond laser in a mushroom configuration, so you can see the edges. Now, what was thought the Decimex membrane for almost a decade, Harminder Dua, in his excellent study, has shown that there is another layer called the pre-Decimex layer. Whether that's a novel layer or it's part of the stroma is, again, something that can be debated. But surgically, it helps us define what happens when we inject air. So when you inject air in the classic type 1 bubble, which starts from the center and goes to the periphery, the separation is between the stroma and the pre-Decimex layer or the Dua's layer. Since there are some peripheral adhesions, that's why you get the dense white frothy margin when air goes into these fibrous separations of the stroma. In contrast, the type 2 bubble is between the pre-Decimex layer and the Decimex. So there are no stromal fibers here. So that's why the margin of this bubble is very well defined. It has a very sharp margin. It starts in the peripheral cornea and it can extend all the way across the cornea. And it's very thin and it's more prone for rupture. And you can get a type 3, which is a combination of type 1 and type 2, something that starts like a type 1 and then breaks into a type 2 as well. Now, in terms of doing the big bubble surgery, instead of using a needle, people have started using blunt tip bottom port cannulas. You can place them very close to the Decimex membrane without having the risk of perforating through into the cornea, into the anterior chamber. Once you achieve the big bubble, the intraocular pressure rises. So you perform a paracentesis to release some aqueous to normalize the pressure, and then you deflate the bubble using a sharp knife. And this is like one quick rapid motion, after which you can split the overlying cornea, residual cornea, into 4 quadrants, excise the residual cornea, punch out a donor corneal button. For ectatic disorders, we use the same size. For other indications like corneal scars and dystrophies, we can use anywhere between 0.25 to 0.5 larger, depending on your suturing technique. The Decimex membrane is usually removed from the donor cornea, and then it is placed into position. Suturing technique can be depending on your preference of what type of sutures you're used to performing in your penetrating keratoplasty. So you should avoid air injection in eyes where the scars involve the Decimex membrane. That's why I like to perform an anterior segment OCT in all my cases. And if I see any element of the scar involving the Decimex, I would avoid injecting air because that's likely to lead to undesirable effect. You should have a fair idea about your regional pachymetry that can help you plan up to what depth of trephination that you do. Usually like to use a vacuum suction trefine. Each quarter ton cuts down to about 60 microns. Also very advanced keratoconus with the apical thickness less than 200 microns as well. Here the Decimex or the pre-Decimex layer is already quite stretched. So here also if you try to inject air to create a big bubble, you may initiate the bubble, but when you try to expand it to the edge of your trephination, sometimes these bubble can rupture spontaneously. Macular dystrophy gives a very variable response to air injection. So you should always be careful when you do DALK and macular corneal dystrophy. If there is extensive involvement of the cornea with the macular deposits, in my hands, I have shifted to doing a full thickness penetrating keratoplasty. Ideally, someone over the age of 45 to 50 years, I think I would do a penetrating keratoplasty because it's usually associated with poor endothelial function as well. So despite not having a perforation, there have been instances where I've had double anterior chamber that does not resolve with repeat air injections as well. So those are the various cannulas that are available for air injection. Once you get your big bubble, if there is a lot of emphysema and you're not very sure, you can use the small bubble test that's described both by Parthasati and Fontana. So the air bubble remains in the periphery, and once you deflate the bubble, the small bubble moves to the apex, indicating the presence of the big bubble. Even for bubble deflation, you can make the bubble deflation a little easier without the risk of perforating the posterior layer. So you do a paracentesis, release aqueous, soften the eye, and then you place cohesive viscoelastic on the corneal surface, after which you can take your knife and you can pass it through the viscoelastic to create an opening, and the viscoelastic retards the egress of air, and that's why it makes the process a little gradual, giving you more time to remove your knife before the posterior layer snaps back into its position. Instead of using air, you can use cohesive viscoelastic as well to create what is called as a viscobubble. So here you have to have a softer eye before you inject the viscoelastic. As the viscoelastic is more dense, it requires greater amount of pressure. So you place an air bubble also into the eye, so you can use the reflex against the air bubble to decide how deep your cannula is, as described by Mellis. And once you get the viscobubble, the rest of the steps are pretty much similar. So this is something that can be done if you have a failed air injection to create the big bubble. So you have had multiple attempts at air injection and you fail to achieve the big bubble, then you can place the cannula attached to a viscoelastic filled syringe, and then you can inject viscoelastic and try to create the viscobubble. Now, when you have, this is a manual technique, so we tried air injection, did not work. So in the periphery, we go and create a plane of separation. And the central part is pretty much similar to what has been described by Enrique Malbran. That's the Malbran peeling technique. So if you're at the desired depth, you will find that you don't need to dissect too much in the corneal apex. It just peels off on its own. And this also fairly gives you a uniform plane, and you can achieve good results, although the visual recovery is slightly delayed compared to the big bubble technique. But a lot of papers comparing the two techniques have shown similar visual outcomes when analyzed 15 to 24 months later. So that's how the patient looks post-operatively after doing a DALK. The best part is you see good endothelial cell counts, and suture removal, initially we thought we could do much earlier, but then we realized that the graft-host junction healing does take time despite having an intact posterior layer. So we pretty much try to keep the sutures for a much longer duration, and we have found that early suture removal often can lead to undesirable astigmatism. Femtosecond laser has the advantage that you can create customized incisions, either using the zigzag or the mushroom shape, which are more commonly used. These allow better apposition of the donor with the host, and also because of the larger surface area of the graft-host junction, you get stronger wounds. And here, in this case, the suture removal can be attempted a little earlier without inducing significant amount of astigmatism. Now, just to show you, this is a patient who had intracorneal rings and was not satisfied with the outcome. So we used the femtosecond laser. I'm working with a Zima Z6, created a mushroom-shaped corneal incision where you have an anterior corneal diameter is larger than the posterior. Remove the intracorneal rings, and then using the same track, we introduced our blunt cannula, and you can see that we are enlarging the big bubble, deflated it, and then you can excise the residual stroma, prepare your donor tissue. It's the same size, diameter, same parameters, and you can place sutures to secure it in position. When using the femtosecond laser, be careful about oversizing, because the femtosecond laser is so precise. If you oversize it even by 0.1 to 0.2, sometimes you may find that the apposition becomes a little bit difficult to perform. That's the post-op appearance of the femtodal. You can see much better edge apposition, and this patient had uncorrected visual acuity of 20/40, improving to 20/20. That's how is anterior segment OCT and the corneal thickness. Intraoperative OCT, yes, it's useful, both for the big bubble as well as the manual technique. It's an expensive device, but if you do have it, you can create the track that you make with the pointed dissector and then look at it on the anterior segment OCT, intraop OCT, and if you find that it's not at the desired depth, you can create another track which goes much deeper, closer to the decimus membrane. If you're doing a manual DALK, you can use it to assess how much of residual stroma is still remaining, which can help you decide whether you need to do another plane of dissection. And also, if you encounter complications, sometimes it can help you assess the site of perforation once you have placed your suture to see whether there is apposition of the two layers or there is still any separation that requires you to address it intraoperatively. So in conditions where you have corneal scars, like this is a patient with high drops, a manual DALK can still be performed and you can have reasonably good visual outcome. Even for conditions like keratoglobus, you can do a large diameter DALK. So that's the same patient post-operatively, you can see. For non-healing, this is the acanthamoeba keratitis, which was not responding to medical therapy for almost over 2 months with a waxing and waning clinical course. So we did do a large diameter DALK, and it required post-operative continuation of the medications to achieve a complete elimination of the infection. Now, this is a patient with a corneal degeneration, lipid keratopathy with spheroidal. He waited till the visual axis was involved. And then instead of doing a full thickness graft, we were able to do a DALK for him. So the exposure of the predecimus layer in the center was done only for the 5 to 6 millimeter area. For surface reconstruction, DALK is also quite useful. So you know that in a vascularized bed, doing a penetrating keratoplasty has the increased risk of rejection. So here these are unilateral chemical injury cases where we combine a surface reconstruction, doing a large diameter DALK in combination with conjunctival limbal autograft, and we did not have to do two surgeries sequentially. We were able to achieve good results with one single surgical outcome. Now moving on to posterior lamellar keratoplasty, which again seems to be the more popular surgical technique for corneal transplantation these days. Compared to penetrating keratoplasty, endothelial keratoplasty has the advantage that it avoids any surface incisions or sutures. Thereby, it has a smoother topography, faster wound healing. Visual rehabilitation is also quicker because you perform the surgery through a 3 millimeter incision. You have greater tectonic stability. By transplanting lesser amount of donor tissue, you have reduced rejection rates as well. And all the associated complications with sutures can also be avoided when you do endothelial keratoplasty. It's done commonly in our practice. We come across pseudophakic or aphakic bullous keratopathy from complicated cataract surgeries. Fuchs endothelial dystrophy is much more common in the West, but in our population, our cataract surgeons perform the surgery first, so we don't exactly know the exact incidence of Fuchs, but yes, we do see them, but they are not the most common indication. Other indications would be failed corneal graft, ice syndrome, post-strap tube eyes, and congenital hereditary endothelial dystrophy. The evolution of endothelial keratoplasty, I've gone through all the 3 surgeries. I started off doing DLEK procedure, deep lamellar endothelial keratoplasty, or what Melis coined the term posterior lamellar keratoplasty back in 2003, 2004. And here you had to dissect the host cornea at about 80% depth, cut out a central 8 millimeter disc from the host cornea. Similarly, prepare a donor cornea, lenticule, and then try to fit that into the space that you have created in the host cornea. So this was more time consuming and it was not very popular because it involved a lot of manual dissection. Then subsequently, Melis showed that you don't really need to dissect the host cornea. You can simply prepare your lenticule, just strip the decimus from the host cornea and put in your lenticule, the decimus stripping endothelial keratoplasty. Mark Gorovoy showed us that you can prepare the donor using a microkeratome, the decimus stripping automated endothelial keratoplasty. That's when it really became much popular, and iBank started giving you pre-cut tissue. And in current times, we have the isolated transfer of the decimus membrane, the DMEK, or the ultra-thin dissect, which are the more common surgical techniques. And if you look at, again, the numbers from the iBank Association of America, you will find that there is a gradual increase in the number of DMEK procedures being performed, from about 1,500 in about 2013 to about 13,000 in 2019. That's a very rapid growth, almost a 41.2% increase in the DMEK procedures. So something about DSEK, yes, you can prepare it manually, the donor, by placing the tissue on an artificial chamber and using lamellar dissectors. Quite successful, less expensive, especially if your eye banks don't give you pre-cut lenticules. Or you can prepare using a microkeratome where the interface is much more smoother, and the visual recovery with the automated preparation is definitely much faster. But again, there's a paper by Price, when they compared the visual outcomes at 1 year, they found that in both the groups, the final visual outcome was almost the same. Yeah, but if you use a donor tissue prepared with a microkeratome, the visual outcome is much more rapid. So one of the steps which is common to both DSEK and DMEK is that you need to strip the host Decimus membrane, especially if it is not healthy. So in Fuchs, where you have a lot of gutted changes and the Decimus membrane is significantly thick, you need to remove it in an atraumatic manner. Size of the Decimus stripping, we used to do same size for our DSEK cases, but in DMEK, studies have shown that you do it little larger than the size of your donor DM, and that can help reduce the rate of donor dislocations as well. So what we have done now is that even for our DSEK cases, we recommend that you make it about 0.5 millimeter larger than the size of the donor lenticule that you're putting in. It's important not to traumatize the corneal stroma, especially if your visibility is not very good and the corneal stroma is edematous. If you apply a lot of pressure, you can end up disturbing the stromal fibers as well. I like doing it with a dilated pupil and cohesive viscoelastic in the anterior chamber, because it allows the anterior chamber to remain formed and stable. But you can do it by placing an air bubble in the anterior chamber, where the visibility of the Decimus membrane is going to be really much better than what you see against the viscoelastic. But the problem is the air keeps leaking out, and you have to have repeated injections of air into the anterior chamber, or you can connect an air pump through an AC maintainer into the anterior chamber, which continuously injects air whenever it's leaking out. In terms of donor insertion, you can use one of the injector systems like the Bucin Glide, or this is a Macaluso inserter. You put a little bit of cohesive viscoelastic on the endothelial side to protect the endothelium. So basically the donor tissue curls with the endo in, and this has a plunger behind, so you can place the tip of the injector into the anterior chamber, use a microforceps to grasp the donor disc, pull it into the anterior chamber and watch the disc unfold. Then you can discontinue the AC maintainer before you let go and place an air bubble to do a complete air fill, and close the wound with 1 or 2 sutures. You can stroke the surface to position the donor disc into the ideal position, and you can place a bandage contact lens, especially if you have removed the edematous epithelium from the corneal graft. Post-operatively, you do a complete air fill, but then you have to watch out for any evidence of pupillary block. To avoid that, you can consider doing an inferior peripheral iodectomy, either preoperatively or intraoperatively, using either a vitrector or a surgical PI. Then you don't have to worry about the complete air fill and the risk of pupillary block. But if you have not done an inferior PI and you have a complete air fill, you need to examine your patient an hour later after surgery. And if you feel that the intraocular pressure is raised, or if there is any evidence of initiation of pupillary block, you can burp out a little bit of air in a sterile fashion from one of the paracenteses. And the air usually stays for about 3 to 5 days, and thereafter, and by that time is usually sufficient to have a good secure adhesion between the donor lenticule and the host cornea. Patient should be advised not to rub the eye, and you should not attempt to measure intraocular pressure using applanation tonometry or the tonopen, because any kind of corneal deformation can result in a separation of the donor disc from the cornea. This is again the case of DSEK done 7 years back, and if you look at the eye, the cornea looks pretty clear. The donor disc is quite thin, uniform in thickness, and the cell count at 7 years is quite good, 1,940. These are various cases of DSEK and DSEK that's been performed, wide range of cases, and you can see even post-graft or post-strap tube eyes, they can be performed. The outcomes in post-strap and tube eyes is not as great compared to the other cohort of population because of change in the composition of the aqueous with the trap or the tube. The cell loss is much more accelerated, and often we find that the need for repeating the graft at 5 years is almost in the range of about 40 to 50%. In terms of DMEK, the advantage is it's again minimally invasive. You don't need any expensive instrumentation like the microkeratome to prepare your donor. You have a faster visual recovery. Because the corneal anatomy is maintained, you have a minimal refractive shift. There is a reduced risk of rejection and better utilization of donor tissue, because after you strip the decimets, the remaining stroma can also theoretically be used for an anterior lamellar keratoplasty, especially in parts of the world where donor tissues are hard to come by. In terms of donor preparation, here in our country, the eye bank does not give us pre-stripped tissues. So we perform the stripping of the donor prior to surgery. You can make a partial trephination, a large diameter trephination, then do a partial peel of the decimets, then you create a stromal window. The stromal window is basically to access the stromal side of the decimous membrane, where you can create a S or an F stamp, and then you go back and do a 8 millimeter partial punch. The peripheral rim of the detached DM is removed, and then the final stripping is completed, and you have your 8 millimeter donor DM that's completely free. The tissue wastage rate is in the range of about 1 to 2%, but even if you damage the donor cornea, the donor DM, the tissues can still be used. You can use either an eccentric trephination, or you can use trephination of a smaller diameter. And Kashif has also done a lot of hemi-DMEK, so he knows how to work with smaller size donor grafts as well. One should avoid younger donor tissue, because below the age of 40 years, we find that it becomes very difficult to identify the edge of the decimets, and also the peeling. It's a little bit more elastic, and once you have peeled it, the tissue goes into a very tight scroll, which may be a bit challenging to unfold once inside the eye. So the ideal age of a donor for DMEK would be somewhere in the age group between 50 to 75 years. So that's just to show you how with the increasing age, the donor scroll kind of unfolds much easily. Pre-stripped tissue, you can get either tissues which are partially stripped and stamped. So all you have to do is to just make your 8 millimeter or a 7.5 millimeter punch and use it for surgery. And these days you get the pre-stripped, pre-stamped, pre-loaded donor tissue, or the patient-ready tissues, which you can just need to attach it to a syringe, flush out the storage medium, and then inject the donor tissue into the eye. Inferior PI is very important. If your corneal is relatively clear, you can think about doing a YAG peripheral iridectomy. Otherwise, intraoperatively, you can do that using a vitrector. But be careful when you use a vitrector, because if you do it for a pretty long time, you can end up eating the zonules and create a track into the vitreous cavity, which can then create problems because it becomes a unicameral eye, and sometimes the fluid can go into the vitreous cavity and push the lens iris diaphragm superiorly. The other way to do it is doing it through an inferior paracentesis, where you make an inferior vertical paracentesis. You can pull out the iris and do a surgical iridectomy using a microscissors. Intraoperatively, the problem of doing a surgical PI is that sometimes you can have bleeding from the PI, which can make the surgery a little bit more challenging to perform if the bleeding is not controlled. In terms of insertion unfolding, you can use either various IOL injectors or the glass injectors. I have worked with both, and I think both of them perform relatively well. Advantage of using a glass injector is that you can visualize the donor DM much better. So you try to insert the donor into the eye with the open end of the scroll facing towards the surgeon and not towards the iris. You can load the donor tissue either from the tip make sure your nurse keeps replenishing the fluid in that corneoscleral rim, because sometimes you run out of fluid and your donor tissue has not yet come into the tip of your cartridge. Or you can take the tissue into a glass Petri dish and you can load it from the broader end of your injector, as what we do with a glass injector from Goiter. So this is what I was talking about, the open end of the scroll. You can see this V pattern that you see at the tip. This open end of the scroll should be facing towards the surgeon. So the tip goes in bevel down, but once your tip is inside the anterior chamber, you can rotate the tip so that this open end of the scroll starts facing towards the surgeon. And then you gradually insert the tissue into the eye, and that makes unfolding much more easier. So the open end of the scroll should not be facing towards the iris. So let's look at some of the videos. So here you can see I went in, and then I look at my scroll and I try to get the tissue into the eye with the open end of the scroll facing towards me. Don't be in a hurry to remove the tip of the cartridge from the eye. Allow the pressure to normalize, because if the pressure is high in the anterior chamber, as soon as you remove your tip, as fluid leaks out, it can bring the tissue out as well. And also, if you wait for some time, normalizing the pressure, the tissue also unfolds a little bit, thereby makes it easier so that it doesn't roll over to the other side. The tapping can be performed using two cannulas. You can use one cannula in the center to kind of fixate the tissue and use the other one either to tap at the periphery. You can sometimes release fluid from the paracentesis also as you to unfold the peripheral edge. And always when you inject air, make sure that the tip is below the donor tissue. You see that by the change of the color of the cannula, and then you can inject air in a gradual fashion. Sometimes I inject air in a two-stage where I put in a small air bubble first, ensure that my tissue is well centered, and then I go in and enlarge the bubble. So just to show you a peripheral tapping technique here, the tissue is in something like a taco fold. So before we unfold, we will try to inject some fluid peripherally to get the tissue to shift. You can see, yeah, so basically it's like to get it into a double scroll kind of configuration. And then you tap in the periphery. Keep the chamber partially formed, so it's neither too deep nor absolutely flat. So, and then using two cannulas, shallowing of the chamber at one end, you move the tip to the donor tissue to the desired position, let it go gradually, and then the other tip of the cannula we use to stabilize the open end. And then here you can see I'm tapping in the periphery. At the same time, you can release some fluid from the paracentesis or the main incision, and that can also help you unfold this tissue as well. You can see the F stamp that ensures that my tissue is in the right orientation. And once you're well centered it, you can go in with your cannula. I usually like to use a 30 gauge cannula, and you go below the tissue. Always form the chamber a little bit before you slide in your cannula, because if your chamber is flat, you can catch the iris, and not very careful, you can induce a DM, an iridodialysis as well. Here in this video, if you see, you will see that, I'll just play this back again. I injected my air bubble first, and when I'm injecting the second air bubble, you can see the second air bubble has actually detached the decimates because it's not continuous. So you can see that this part is clear, but the tissue has got folded in between the two bubbles. So I have to go and release this air bubble. As soon as I release it, the tissue unfolded itself. So this is again something that you have to watch when you're injecting air. If you have a tissue that's in this configuration, the other way is to use the Dirisamer maneuver, where you fixate one edge of the tissue with one cannula, and the other one you use like a drum roll or a carpet unrolling maneuver, where you can unfold by tapping the cornea, just inner to the tissue fold, and then unfold. Unlike a DSEK graft where you use golf strokes to move the tissue, here we just tap in the periphery outside the donor graft to get it into desired position. Again, you will see that before we inject the air, we will always do a little bit of injection of fluid just to push the iris back, and then we go and inject the air bubble. Always keep the tip in the center and not in the periphery, because if you keep your cannula in the periphery and inject air, the air bubble will displace the donor graft to the opposite end. So always bring it to the center, and then you inject air, And I recommend that you use a tuberculin syringe, keep about 0.1, 0.2 cc of air, so that you don't end up a sudden injection of a large amount of air. You can create a small air bubble, and then you go back into the same bubble and enlarge the air bubble as well. In very vitrectomized eye or high myope, which have deep anterior chamber, sometimes you have to use an air bubble on top of the donor DM, that is within the scroll, and then use that air bubble as an instrument to help you unscroll the donor tissue. Otherwise, you end up tapping for a considerable period of time, and you find that the tissue keeps unfolding and then re-scrolling back. So here I'm using the air bubble to unscroll, and when it's unscrolled, you can gently remove the air bubble and then go below it and place a large air bubble. For tight scrolls, this is again something that I like. I designed this cannula which has 2 side ports. It closes at the tips. You can give a burst of fluid. You can see that as you inject fluid, it helps open up the tight scroll. You can wait for a while to release fluid from the paracentesis, shallow the chamber, and the rest of the unfolding is pretty much the same as what we saw in the earlier videos. Endo-in pull-through technique, yes, this is something that we have done, especially in complicated cases where there may not be enough room for you to maneuver the donor scroll, like post-trab, post-tube, or cases with extensive synechia. So we stain, this is basically like folded like a DSEC graft with the endo-in technique. So you can see that the graft with the endo-in is pulled into the eye using a forceps. The AC maintainer is running very slow. You keep holding the graft, tap it, let it open up, and then place an air bubble within the scroll. Remember, it's endo-in, and then you move the air bubble to unfold the graft. And once it's in the desired position, you enlarge the air bubble. This was a recent paper from Don Ultan's group. They frequently use the endoglide to put in their donor tissues in DMEK because their eyes are having very shallow chambers, and the anterior segment is smaller than what you see in Caucasian eyes. The cell loss was quite comparable to the other techniques that we have been using, an average of about 33.6%, ranging from 7.5 to 80.4 at 6 to 11 months follow-up. Identifying, besides using the S or the F stamp, you can use a handheld slit lamp to look at the orientation of your scroll, or if you have anterior segment intraop and anterior segment OCT, you can use that to, it becomes very easy to look at the configuration of the scroll, and you can use it during your unfolding process as seen in this video. Post-operatively, I still see my patients an hour later, even if I have an inferior PI, just to make sure I see that small meniscus of fluid, because sometimes in soft eye, you can overfill the anterior chamber, and even the inferior PI, if it's not at the extreme periphery, can get blocked, and you can have some element of pupillary block, so you may have to release some air. Comparison between using sulfur hexafluoride 20% versus air has shown that both are equally effective and don't have a detrimental effect on the endothelium. And in fact, the detachment rates are lower when you use 20% SF6. So for people starting off with DMEK surgery, we always advise them that for your initial cases, you can use 20% sulfur hexafluoride for tamponade. Only thing you need to watch out is that often we use myotics intraoperatively, your pupil becomes myosed. And if you use long-acting gas, and if you don't dilate your pupil post-operatively, the incidence of posterior synechia is higher. And if your patient has a pre-existing hydrophilic IOL in the eye with a prolonged gas tamponade, the incidence of IOL opacification, the risk can be much higher. So the ideal case for DMEK should be something that has adequate visibility. The anterior segment is normal without any large peripheral iridectomy defects or vitrectomized eye with communication into the posterior segment, or eyes with traps and tubes. These are again something where we have done, but they are much more challenging to perform. So these are some of the common indications for which a DMEK surgery can easily be performed. Even the visual outcomes are so rapid. So this is one of my patients with Fuchs, where we did a triple procedure on the first eye, and within a week, we performed the second eye as well. This was the pull-through technique with the ACIOL. You can see the 3, and you can see within 2 weeks, the cornea is looking very clear with a nice outcome. And the advantage here is that unlike a DSEK graft, where the peripheral part of the graft has a risk of touching the iris and developing posterior synechiae, a DMEK graft kind of sits very well. So for patients with pre-existing stable anterior chamber lens, instead of doing a standard DSEK, I would perform either an ultra-thin DSEK or a DMEK. So these are again for complicated DSEK cases where the patient had an undesirable outcome. We went back and did a DMEK. This is again another patient where has a unstable ACIOL, where a DSEK was done, it failed. So we went back, removed the DSEK graft, did a Yamane technique of scleral IOL fixation, and then we did a DMEK. And you can see this is day 5, the small air bubble superiorly, and the eye is already very clear. In complex cases like CHED in pediatric eyes as well, DMEK seems to perform quite well. This is ICE syndrome, where originally we had done a DSEK, and it came back to us 7 years later when he had developed a cataract. The cell counts had reduced considerably. So we went back, removed the DSEK graft, did his cataract surgery, pupilloplasty, and did a DMEK, and he did quite well after that. The problem both with DSEK and DMEK is that the donor is placed without any secure attachments like the use of sutures. So there is always a risk of donor dislocation. It's more common in DMEK than DSEK, usually because of inadequate support. The air bubble or the gas bubble disappears quickly, or there is some leakage with hypotony. There is some external pressure like eye rubbing, or you have damaged the graft so much there is poor endothelial placement or a reverse placement. These can put it at risk. You can always do a rebubbling and repositioning of the donor graft. Can be done in the operation theater or on slit lamp. I prefer to do it in my LASIK room, and seems to work quite well in majority of cases. But again, if you really had to replace, it's still not a very complex procedure. You can open up the original incision and you can remove the graft and put in a new one. Again, the rate of dislocation again varies between the experience of the surgeon. There have been reports varying from 0% to as high as 40%. In my hands, when I started off doing that, I would say that the risk of detachment was lower than 10%, both for DSEK and DMEK as well. But DMEK is sometimes a little unpredictable. I think it has something to do with the donor characteristics as well. There have been instances where what seems to have been a perfect surgery and a perfect outcome for the first couple of days. So that's why I always like to see my patients at least for 1 week follow-up by when the air bubble or the gas bubble has reduced considerably, because that is the time when you can identify if there is any early separation of the Decimex scroll. If it detached over more than 30% of the area, or there is any central corneal edema, then I think rebubbling is something that should be done. If just a small peripheral separation, you can watch it. But I usually use anterior segment OCT to follow up these cases, and if I see progressive worsening, my tolerance level for rebubbling is quite low. The advantage of DMEK is the speed of recovery. Definitely, you can see that within the first 4 or 5 days time as well, the cornea starts clearing up pretty well. A lot of patients by 1 week, they're almost like 20/40 if they don't have any pre-existing corneal stromal scarring or any other problems. Comparative study between DSEK and DMEK have shown similar endothelial cell loss, but the percentage of patients achieving 20/20 or better are much higher among the DMEK eyes. So that's again showing you the patient where both eyes were done. And looking at the posterior corneal curvature, you can see that the posterior corneal curvature is steeper post-DSEK as compared to DMEK, where it is almost like a normal eye. This paper comparing the posterior curvature, they found that the DSEK eyes have a posterior curvature is steeper, which can explain the hyperopic shift. And this has to be taken into consideration if you're doing a combined surgery, like a cataract surgery with an intraocular lens implantation. Usually you aim for about -1 to -1.5 post-operative aim for myopia. In DMEK, you can do a triple procedure, and that does not have any impact on the attachment rates of the donor DM or the endothelial cell loss. This nice paper from Melis, published back in 2011, showed that the corneal edema that occurs in Fuchs dystrophy, and you get a cataract, the edema tends to induce a little bit of peripheral myopia that results in the immediate hyperopic effect that you see after DMEK. But if you wait for 2 to 3 months and the peripheral edema resolves, this slight hyperopic shift that you see also disappears. So you don't really need to worry about the immediate little bit of about 0.75 hyperopic shift that you see after doing a combined surgery. So for me, I usually aim for about minus 0.5 when I'm doing a cataract surgery combined with DMEK. The risk of rejection, yes, this paper, original paper from Frank Price in 2012, showed that the DMEK had 15 times lesser risk of rejection compared to DSEK and 20 times lesser risk compared to PK. So their incidence of rejection was only about 1%. But various studies in literature have shown that this risk of rejection varies between 1% to as high as 3 to 4%. This is my initial DMEK patient done in 2009, and he still comes for a follow-up after 11 years. And he's presently not using any topical steroids. And he still maintains a very good graft. His fellow eye, which had a full thickness graft and had a trabeculectomy done, we did his DMEK, and 8 years follow-up, he's still maintaining 20/30 vision, although in this eye, because of his trabeculectomy, I've still continued him on topical fluorometry. And the paper published in ophthalmology by the American Academy of Ophthalmology does show that the visual recovery time, the visual outcome and rejection rate, DMEK is superior to DSEK, induces less refractive error, and the endothelial cell loss is comparable to DMEK as well. And if you look at a transition of an experienced DSEK surgeon to DMEK, and this paper comparing the last 100 DSEK cases with the first 100 DMEK cases, more eyes reached 20/20 in the DMEK group compared to DSEK. They had more incidence of posterior synechiae and the dislocation of the donor requiring rebubbling, and the endothelial cell loss was slightly higher in the DMEK group compared to the DSEK group, and that can be understood from the initial learning curve when you are doing DMEK. But what about ultra-thin DSEK? If you compare, you find that this, again, paper from Massimo Busin, the ultra-thin DSEK is basically when your donor lenticule is less than 100 microns in thickness. Normally for DSEK, the lenticule thickness can vary anywhere between 150 micron to 200 microns, which when you're transplanting it, but it tends to thin down with the resolution of edema, and later on it can vary anywhere between 80 to 140 microns. Whereas the ultra-thin DSEK graft at the time of transplantation can be sub 100 microns, but later on it can go down to about 40 to 50 microns thickness. The rejection rates for ultra-thin DSEK are lower than DSEK, and the visual outcomes come close to DMEK, although in the immediate post-operative period, DMEK outperforms ultra-thin DSEK. But when you look at them over a 12 to 15 month period, you find both of them achieve the same visual outcome. In terms of this, again, a comparative RCT comparing ultra-thin DSEK with DMEK, DMEK seems to slightly outperform ultra-thin DSEK. And also in terms of induced high order aberration, the posterior high order aberration seems to be higher when you do an ultra-thin DSEK compared to a DMEK, and that can explain why the visual acuity was slightly better when a DMEK was performed. But ultra-thin DSEK does have a role, and it requires your eye bank to give you ultra-thin donors, or what in US they are using nowadays called nano-thin donor tissues, which are maybe less than 70 microns, and you require to do a double pass where the initial cut you can perform with a microkeratome with a 300 micron head. You do a pachymetry, and depending on what corneal thickness you have left, you can use an appropriate microkeratome head to do the second pass from the opposite side. Or sometimes we use a single head, which is 400 microns, and do a single pass and try to achieve a thinner donor lenticule. However, in personal experience, I have found that the intraocular pressure in the anterior chamber does have a role to play. And if you're not very careful, especially after the first pass, when your donor tissue is now thinner and you're passing the microkeratome, you always have a risk of inducing a perforation at the time of making the second pass. So the tissue loss rate can vary from 4% to 7% when you're trying to prepare tissues for ultra-thin DSEK. So that's showing you the preparation of the graft using a 400 micron head. So that's pretty much similar. The anterior cap that you get from this 400 micron can still be used for an anterior lamellar keratoplasty. We mark the outline of the cap that the bed that we have created, put the stamp, and then we punch out the donor tissue. In terms of inserting it into the eye, it's much more floppier than a DSEK graft because it doesn't have any enough stromal tissue. So what we do is, before we transfer it to the injector, we do like an endo in trifold with a little bit of cohesive viscoelastic in the center, and then we transfer it to our inserter. Because without doing that, if you try to shift the tissue has a tendency to curl on the endothelial side. And inserting into the eye, so you can say this is a cornea where the visibility was not too great. So instead of a DMEK, we decided to do a ultra-thin DSEK. And because the tissue is thinner, it doesn't open up as quickly as a DSEK graft. So it takes a little bit longer. You have to sometimes manipulate a little bit, and you put an air bubble, and you can see you can put in much larger graft than what you do with a DSEK because the tissue is being much more thinner. The peripheral thickness is also less. So the chances of developing peripheral donor iris adhesions are also lower. So you can see that I have to tap the surface to get the donor tissue to open up. And then you put a large air bubble. So post-operative outcome, you can see that on slit lamp, when you see the posterior lenticule can hardly be visualized. The graft is much larger in size. So initially it was about 103 microns, and at 1 month follow-up, it's down to about 56 microns in the center, 70 microns in the periphery. This is another ultra-thin DSEK graft. You can see that it's quite thin. These kind of corneas where visibility is an issue, you can safely do an ultra-thin DSEK graft. And recently this device has been described, which kind of standardizes the pressure within the artificial anterior chamber, which can again ensure that the cut that you make with the microkeratome is uniform across various donor tissues. In looking at 5-year outcome, you can see that progressively the best corrected visual acuity of 20/20 or greater, it keeps increasing every year, starting at 36% in the first year, and in the 5th year it increases to about almost 53.5%. And the rejection risk of rejection, you can see it's less than about 5%. Even in the randomized control trial, which Chamberlain had published, if you look at the rebubbling rate in DMEK graft had a 24% rebubbling rate, whereas in ultra-thin DSEK graft, the rebubbling rate was lower. So the preparation between ultra-thin DSEK and DMEK is quite similar. Insertion is easier because it's quite similar to DSEK, whereas in DMEK there is a learning curve. You have to learn how to unfold the tissue with tapping. The post-op rebubbling is lower. In complex eyes, ultra-thin DSEK is easier to perform than a DMEK, which can be challenging. The visual outcomes are slightly better in DMEK, but over a period of time, I think both achieve the same percentage. Rejection rates are again slightly lower in DMEK, and the endothelial cell loss are comparable between the two. This is especially in times of COVID when eye banks may not be able to provide you with good donor tissue. This is a gamma irradiated donor cornea provided by Keralink International Eye Bank. Here, the tissue, this is an acellular tissue. It doesn't have any viable endothelium or keratocytes. We have used this for our performing DALK, and we have found that the visual outcomes are quite good using the vision graft. So bioengineered corneas, we have heard quite a lot about them, but they are still not achieved widespread usage in clinical practice. But this is something in the future, it does have a role to play in doing customized corneal transplantation procedures. In terms of cell-based therapy, yes, cell cultures, there's a lot of pioneering work being done by Dr. Kinoshita in Japan, where they have been able to remove the decimets, the endothelial cells from the decimets membrane and inject cultured endothelial cells where the patient lies face down for about 3 hours and thereafter uses Rho kinase inhibitor, and they have achieved good visual outcomes in human studies as well. We are still awaiting the final outcomes and commercial availability of the Rho kinase inhibitors, which will then make doing endothelial keratoplasty much more easier. What I have not covered in my presentation is basically decimet stripping only, which is again a procedure where you do a isolated removal of the unhealthy decimets membrane in fuchs dystrophy. It doesn't fall under the purview of corneal transplantation because you're not transplanting anything. You are basically removing the decimets membrane and then giving topical Rho kinase inhibitors to encourage the peripheral endothelial cells to slide over and cover the central defect and result in resolution of corneal edema. So in conclusion, corneal transplantation techniques have evolved over the past 2 decades. Basically, corneal surgery has become much more glamorous now. Lamellar surgical procedures definitely have advantages over conventional full thickness surgeries. The use of femtosecond laser and intraoperative OCT definitely have a promising role to play in improving the surgical outcomes. Tissue engineering seems to be the future of corneal transplantation surgery. Maybe over the next 4-5 years' time, whatever we are doing now will again seem very rudimentary with the introduction of cell-based therapy for corneal procedures. Thank you for your patient hearing.
Thank you very much, Rajesh. That was a very nice overview of the various corneal transplant techniques. The videos were excellent. It really lends to the discussion and the arguments you're making. We have a few minutes for questions, if you allow, Rajesh. Any questions from the audience? I have a few while people come up with some questions. For your superficial anterior lamellar keratoplasty and your use of the femtosecond laser, do you find that some pathology may interfere with the actual laser action? Yes.
That's why if you have significant amount of opacities, you may not achieve a very clean dissection under the opacities. The Zima, because it has it has a wider focusing beam, because the distance between the laser and the cornea is quite less, it can sometimes see across the opacities. Whereas other femtosecond laser, where the distance between the laser and the cornea is quite more than the Zima, then you have very narrow focusing beam, so they cannot see through the side of the opacity. So then you may have difficulty in separating. So it may require some amount of manual dissection as well. So in those situations, doing that 2-stage superficial anterior lamellar keratoplasty using the microkeratome would be a much better option.
Okay, and we have some optometrists and some techs who are in the who are attendees here. What are your pearls for the post-operative exam in, say, our DMEK or DSEK endothelial keratoplasty patients?
Well, when you see post-operatively, you basically look at the intraocular pressure, which again you cannot measure using the standard applanation tonometry, but you can use finger tension or digital tonometry to have a fair assessment whether the pressure is normal or it's raised compared to the fellow eye. People have used non-contact tonometry to try and see if they can get a measurement, but I usually don't recommend that since I see my patients myself. I try to, and clinically, when you look at if you have debrided the epithelium intraoperatively, you look for a complete epithelial healing because you would not want to have a non-healing epithelial defect. You try to use a fine slit and look at the attachment of the donor with the cornea, any evidence of any separation for which the case may need to be referred back to the primary surgeon for performing rebubbling. And in terms of usage of medications, we use a tapering dose of steroids starting 6 times a day, and it is tapered over a period of 2 months, coming down to about twice a day, which is continued for a period of 6 to 8 months. And if it's for an uncomplicated corneal situation, then we, for a DMEK, we switch over to once a day, which they continue for about 2 years. But for a DSEK, we continue twice a day for the first year. And thereafter, based on clinical assessment, maybe we can keep it once a day. In terms of lubricants, they do continue with the lubricants for 6 to 8 months as per the patient's requirement. The topical antibiotics usually continue only for a week, or if there is a bandage contact lens, then it continues till the time the bandage contact lens is on the eye, which for me, I like to keep mainly for the first week, or if you want, you can extend it for 2 weeks duration.
Okay, and another question I had for you is, I find, although DALK may be some of the more technically challenging work that we do, some of the DSEK cases we're doing now are really tough because our DMEK skills have improved over the years, and so the majority of our first-line procedures is DMEK. So in our DSEK group, those that have these, vitrectomized eyes, the tubes and shunts and stuff, what are your thoughts and what are your recommendations to help that graft, that DSEK graft, stick in place afterwards? Some people have used sutures. What do you do?
I have shifted to doing ultra-thin DSEK, and I find that ultra-thin DSEK is quite useful because it sticks much better. Even if you can achieve a good air fill intraoperatively, and post-operatively, even day one, if you find that the air bubble is missing from the anterior chamber, the ultra-thin DSEK graft will have a lower tendency to detach as compared to the standard DSEK lenticule that you put in place. And as you rightly pointed out, you can consider placing a suture at one end of the graft, maybe a full thickness suture through the cornea, to ensure that your graft, even if it separates, it does not dislocate, it kind of stays in place. And also, if you want, in such cases, we tend to use gas more than using air because we want the tamponade to last for a slightly longer period of time, especially in eyes with tubes and traps, where if you just use an air fill, sometimes the air disappears much faster. People have recommended injecting a little bit of viscoelastic into the tube before you inject the air. That can also avoid the air from going away much quicker from the anterior chamber.
Okay. Another question I often get from trainees is when you're doing DALK surgery and you have, say, a superficial scar from infection, you don't have significant thinning. Do you debulk the stroma before you do the air injection, or do you do it right away?
Well, I usually debulk, but there are a lot of surgeons who don't debulk, who straight away go ahead and inject air. For me, debulking is advantageous because it allows me to place my cannula at a much deeper plane. I don't get too much of emphysema because there is not enough stromal tissue to create that emphysema. And also, once I achieve my big bubble, I don't spend time trying to debulk at that point of time. I can straight away go ahead and deflate the bubble. So the duration of contact between the Decimus membrane and the iris lens can be minimized. Because once you get the bubble, the next step you do is you release aqueous from your paracentesis to normalize the pressure. Once you release aqueous, your entire Decimus is flattened against the iris. And at that point of time, if you do anterior lamellar dissection to debulk, you're creating lateral movement. And this can sometimes result in endothelial cell loss in the area where the Decimus is touching the lens iris tissue.
Okay.
So again, if you have very thin apex and you are debulking, you can expose the free Decimus layer in the thin apex, and then when you inject air, the air, instead of going posteriorly, the air starts coming out anteriorly. So in such situations, I only debulk in the periphery. So I don't try to expose the central part, the thin apex. So thereby, it kind of serves both ways.
Okay. And you mentioned with endothelial keratoplasty, in particular DMEK, with the minimal refractive changes that occur after surgery, as well as some of the minimal aberration changes. Are you comfortable using, say, toric lenses or perhaps even some other presbyopia correcting lenses in these DMEK patients?
Not when I'm doing a combined surgery, because DMEK involves some amount of tapping. So my biggest fear is that if I put in a toric lens, and after that I put in my DMEK graft and I'm trying to position my DMEK graft, I may induce a shift in the position of the lens. So I usually don't prefer to do a toric lens in combination with DMEK. But Frank Price has recently published a paper where he does a DMEK first and then goes back and then does a cataract surgery with a toric lens. And I have done that for some of my patients. And I find that doing a cataract surgery after a DMEK is quite easy and simple, unless you're dealing with a very hard cataract and the endothelial cell loss is not, between the pre and post, there is hardly any significant endothelial cell loss. Multifocal lenses, based on my experience with multifocal lenses that I have, I'm still not confident that I would be able to put in a multifocal lens because of the loss of contrast. Even if it's very minimal, it does have a fair bit of impact on the patient's quality of vision. Toric lenses I am okay with, but I wouldn't put in a multifocal or a enhanced depth of focus lens for my DMEK cases. How about you? Have you been using any multifocals or EDOF lenses for your DMEK cases?
So we've used toric lenses, as you've described, but not the EDOF or trifocal or any of the bifocal lenses. Yeah. However, we just have had this week approved the iHance lens. And so I may consider doing that because of the lack of diffractive range.
iHance is something slightly different. So it's not as, the expectation of the patient is not going to be as much as what the expectation will be from a multifocal lens.
Sure, absolutely.
So we have been using iHance for our regular cataract surgery as well.
Okay. Another question that came up in the audience: if you face a descemetous membrane rupture during DALK, do you convert to PKP? Is the size of the opening, will that make a difference?
Well, come to think of it, for the microperforations which are very focal perforations, you don't really need to convert to a PKP. I've had instances where I've had premature entry with the trifine, and you have a full thickness cut for about 1 to 2 clock hours. We have sutured that and still continued with a manual dissection to complete the DALK surgery. And usually if you have a perforation, you can get away by placing an air bubble in the anterior chamber. Recently, I had a macro rupture where I burst the bubble and it was a rupture going from one edge of my trifrination to the other. So earlier in that situation, I would convert to a PK. But in that case, what I did was I placed my donor graft on top. Then I had done an inferior PI. I put a gas bubble in the anterior chamber. I went with my reverse Sinski, and the two torn edges, I just opposed them together with a gas bubble. And this patient did well. He had 20/80 vision at 2 weeks. So nice. Even if you have a macro rupture, I think going back what we are doing in DSEC and DMEK, you can still try doing a DALK. In the worst possible scenario, if it didn't work out, I could always go back and do a full thickness graft at a later date. But especially word of caution is that when you inject air, and if you get a type 2 bubble, we have got away by exposing the type 2 bubble in some of our cases, but a type 2 bubble is much more prone to having an uncontrolled large perforation. So if you see a type 2 bubble, don't expose the type 2 bubble, do a near manual dissection up to the decimet and put in your graft. The type 2 bubble will spontaneously reabsorb and you will still have a great outcome.
Yeah, great pearl. In the last few moments here, what is the anesthesia, local anesthesia that you're using for your DALK cases?
You can do that under a retrobulbar or a peribulbar anesthesia, but always combine that with a lid block. What we find is that the block lasts for quite a time, but towards the end of surgery, we find that the patient lid starts acting. So you don't want the lids to start squeezing. And if you're a beginning DALK surgeon where you don't know whether you will need to convert to a penetrating keratoplasty, I think doing it under a general anesthesia would be advisable, so that you, even if you spend a lot of time doing a DALK and then you suddenly have to convert to a PKP, you don't have to worry about the anesthesia wearing off and doing a PKP in a very short period of time.
Okay. All right. Well, thank you so much, Dr. Fogla, for your time. A lot of great pearls. I'm glad I recorded this so I can kind of look at some of the videos and use that to kind of educate myself and our colleagues here. So again, thanks for your time. Thanks for the attendees. This session has been recorded and will be up on our YouTube channel perhaps later on
That's
today.
great. Do send me the link for the YouTube so I can then pass it on to my cornea colleagues and fellows who can then listen to it.
Absolutely. Have a great rest of the day or evening, rather, Rajesh. And thanks again for your time.
Thank you. Bye-bye.
Okay, bye.